Very good morning to the audience, and my very, very special thanks to Dr. Keki for remembering to include me in his course. Of course, I'm not showing difficult situations. There are just different approaches as to how I would deal with a hard cataract. Essentially, it's just 1 minute. Excuse me, the volume is not there. Volume nahi hai? So this is a case of a hard cataract, and this is just one other way of how I would skin the cat here. You're creating a small central trench, and it's a very hard cataract, and the posterior plate is quite thick. So you can see that I have gone and done a phaco chop which goes 3/4 of the way, not a complete separation because I do not want to overly stress the zonules. And if you can see that the advanced phaco dynamics of the machine allows a rock stable anterior chamber, and there is no flutter of the iris too, so which makes it all convenient to carry on with the different maneuvers. And now I go on to the second level where I separate these leathery fibers. So as already the basic backbone of the nucleus, hard nucleus, is been fractured, this last step becomes off quite easily and minimizes the stress which could be on the zonular fibers. Yes, it gets to be a little more prolonged, the surgery, but then the first thing is to attack the first heminucleus, and then you just go on to gobbling up all the nuclear fragments, and the shearing action of the phaco ensures that your CD count is quite low. You need to be careful when you come to the last fragments because the posterior capsule is quite thin in these hard cataracts, and you do not want the posterior capsule to come trampolining into the phaco probe. So you definitely need to bring down your phaco parameters, and then maybe go a little more supracapsular, and then all now is to just do a posterior capsular polishing and get done. This was a very high probe, and you need to mark it. I would like to keep it a little larger rexus, but of course not more than 5.5. A gentle hydro, maybe a multi-quadrant hydro, but I don't want a tense globe as the anterior chamber. The whole eye is a crowded eye. And then I go about debulking the cataract. And then here you can see that I'm making a complete separation of the heminucleus, a complete, because the posterior plate allows this amount of movement and stretch. You can see that on the Centurion, your intraocular pressure sits at 60, and which allows you to play with a range of vacuum as the particular case would demand, with adequate flow rate. And the anterior chamber being shallow makes dealing with these kind of difficult cataract and difficult situations less challenging than what it would appear. And just a little amount of posterior capsular polishing, and you get a premium result with the right amount of rexus overlap. Here this was a total cataract, and the femtocataract platform was used to create the rexus, and I've increased the energy to see whether I'm able to get some amount of fragmentation. But when I stain it, normally I wouldn't stain, but here I wanted to visualize that the free floating rexus had come off. But it is clearly visible that although I had increased the energy on the femtocataract platform, the fragmentation had not occurred. So I just go about debulking the superficial cortex and the epinucleus. But one interesting thing in these total cataracts, this form of cataracts, is it's not so leathery. So it's quite flocculent, and it allows a more easier separation, a lesser stress on the zonules. And again, of course, the phagodynamics of the present day machine ensures the stability which is there, which allows the surgery to perform as if it's just a rock hard stable anterior chamber. And then in no time you're able to gobble up the pieces. You can see the CD is just about 7.6 or 9, which is hardly anything had you not used these advanced phagodynamics. And of course, it is a bit challenging to remove the capsule in the femtocataract platform because it's more vertically cut. You need to go underneath to hold the cortical sheath and remove it. But then you're guaranteed a round rexus and a very comfortable, easy surgery in these total cataracts. Otherwise, you could have had a rexus runoff or a wraparound rexus and a posterior capsular tear, and you're able to place a premium IOL in these cases with the most optimal visual outcome. And you can see all the parameters have been quite optimal thanks to going about the surgery in the optimal way. Now you can see this is again a very dense cataract here, but you are able on a femto cataract platform use multiple grids. So there are grades of planning your phaco fragmentation. So I've used the grade 3 third level, and so all I'm doing, if you can see, is just a mechanical pricing apart the fracture planes which have been already created. There's hardly any phaco energy, just that longitudinal pulse to get bury into the nucleus fragment, and all I'm doing is just separating it. This was a high myope, so I've used an intraocular pressure of 40 because I do not want that sudden deepening of the anterior chamber, which could be more challenging in these hard cataracts, nor do I want a reverse pupillary block to occur in these eyes. And now that I've made the 4 fragments, then it's all about just gobbling up the fragments with doing a emulsification, and always taking care when it comes to the last fragment that I drastically bring down my phaco parameters so that I do not by mistake get the posterior capsule. It's always a bit of a challenge in these femtocataract cases to get the cortex, but that's just an initial learning curve. But once you're able to cross it, then it's just about as routine as it is in a manual phaco. And of course, never stop at missing out on the posterior capsular polishing, and perform the surgery as premiumly as you could. And just it's now all about placing the IOL, going behind the IOL, removing the viscoelastic and positioning it just so that you notice that that's the right kind of rhexis wrap. Now this is again another total cataract, fairly dense cataract, and I've stained the capsule, things seems to be going well, but as I start the rhexis, I realized that that kind of a tactile stimulus which you have when you have a tight anterior capsule on a globe was sort of missing. A doubt comes whether there was a subluxation. I just do a very gentle hydro, and then with lot of trepidation I go in with a phaco probe, but I realize all that I'm doing is just pushing the nucleus. In fact, I'm not actually getting the right kind of trough which I want. And then I realized that that area of dialysis and some vitreous presenting too. So I stop at that time, go in and do the right amount of vitrectomy, so pushes back the vitreous, and then realize that it's time I place the CTR, because delaying a CTR placement in a dense cataract where there's going to be more of a zonular stress would actually increase the area of dialysis. The CTR sort of buttresses the capsular fornices well away, and then I'm able to gently, of course, very gently prise apart the fragment and just get a hold on that leading edge of the nuclear fragment and then chew it up. Of course, I would keep my parameters low in these cases, because we need to remember in a subluxated cataract that the capsular bag is quite lax and the posterior capsule can come suddenly up. And then, of course, again, it's important to get the cortex out. Keeping a CTR is actually a bit of a challenge in teasing out the cortex because it gets ensnared in the capsular fornis, but we need to go ahead and remove it, do a bit of a polishing also, because capsular phimosis is a challenge in the subluxated cataract. And you can see that now I'm positioning the IOL. It's a well-centered rhexis and a well-centered bag, and the surgery has been done quite well. Running you to another scenario. Now this is a hard cataract with a corneal opacity. So there are different ways by which you could deal with this. Of course, staining the capsule is mandatory, but herein I've created my side ports and I'm using an endo illuminator here. Now, endo illuminator could go placed intracamerally, or it can be placed in a pars plana route, and the oblique illumination which is provided by the endo illuminator gives you a great depth of focus which the coaxial illumination of the microscope would not. And as you can well see the ease with which I've created the rhexis, I have enough depth perception, so I'm able to use my chop in such a manner that I'm able to see the posterior capsule and that dull red glow shining through, and I'm able to make those multiple hemisections as is mandated in these hard cataracts. I might at the most bring up the fragment a little supracapsular and phacoemulsify it. You can also see it's further compounded by the fact that there's some amount of floppiness of the iris, so I've even brought down the phaco parameters. Maybe in an extreme situation, had the pupil got myotic, I would have even had to stop the case and use iris retractors, but thankfully that was not necessary, and the surgery seems to go on, excepting that I've gone a little supracapsular, and then of course removing the cortex, and you have a good red glow now, which allows the ease to remove any remnant cortex, and then you are able to place the IOL optimally. So essentially, these are just so many different ways you could deal with a hard cataract, but nowadays, the present day, the combination of the best of machines makes it a fairly easy play. Thank you.